All right. So, good morning. So, what we're going to talk about today is basically the link between diet and disease. And this is kind of important because what it is that this is what we've been talking about so far, which is about mostly weight and diabetes. What we've seen as we've gone on is that, the insulin is really the key factor in all of this. But it leads really to the whole metabolic syndrome, which is this kind of syndrome of obesity and hyperlipidemia and high blood pressure and diabetes. The key really to the whole process is the insulin. So this is really the key player in it. And we've seen how a lot of the dietary factors can contribute to the high insulin levels. But the insulin levels contributes to the insulin resistance, the sugars contributes to the insulin resistance, and there are various protective factors such as fiber and vinegar. So these all lead to the metabolic syndrome, but there's also a link to diseases, and that metabolic syndrome also leads to further disease. So if we go back a little bit, we can talk about the so-called diseases of civilization. And these are very interesting because this has also been called the Western diseases, because what they found in previous studies was when they looked at missionaries and people who went to these primitive societies, what they found is that certain diseases are really non-existent in primitive societies. That is, if you look at African tribesmen or the Bushmen of the Kalahari or any like the Inuit up in northern Canada, there are certain diseases such as coronary artery disease, obesity, diabetes, cancer, tooth decay, constipation. There are a lot of these diseases which really don't exist. And these happen to be most of the major diseases that we currently struggle with. And if you look at missionaries from Africa, what they termed this in the 1950s was they called them the Western diseases because they didn't exist in these populations. And what they said, Dr. Schweitzer in West Africa in 1913, he said that, well, after a while, after the whites come, after a while the natives tend to live more and more like the whites. And his observations led him to attribute this to the fact that the natives were living more like the whites, and this is why all those diseases started to increase in prevalence as they get exposed to the so-called Western civilization. And they weren't sure, of course, what it was about the Western civilization that caused all these problems, but nevertheless there must have been something about it, because it didn't really matter whether they're African, whether they're Australian, whether they're Northern Canadians. It didn't really matter. The same sort of thing always happened. So if you look more closely, the First Nations, so the Native Americans or the Native Canadians, if you look back at previous surveys, so you can look at a survey done in 1910, for instance, in the Indian Affairs Bureau, and what they found was that they almost never found cancer. So that is, malignant disease, if it exists at all, must be extremely rare. And not only that, but even though their life expectancy was equal, it wasn't that they're all dying very young from coyotes and stuff. It was that they were living just the same amount as the whites, but they really didn't have cancer, and they really didn't have arterial sclerosis, which is coronary disease or heart disease and the like, strokes. They didn't have that, even though they lived the same amount. And if you look at the populations like the Native Americans, out of 115,000, they only found 29 documented cases of malignant tumors. This is in 1910. So really, the cancers just didn't exist in their population. If you look at the Inuit, again, in 1952, Queen's University, they published a paper, and it says, it is commonly stated that cancer does not occur in the Eskimos. And to our knowledge, no case has so far been reported. So in fact, these people were considered to be protected from cancer. In fact, they were actually sending people to study the Eskimos, which is what they're called at the time, to see why they also didn't get diabetes. So they are protected from diabetes, they are protected from cancer. And they didn't understand. They thought it was something to do with the genetics, that they didn't get it. If you look at the town of Upernavik, which is a town of 1,800. In fact, they could only find one case of diabetes in that whole time, which is a time span of almost 25 years. What's interesting, of course, is that since that time, as they've become much more westernized, cancer is rampant, obesity is rampant, and diabetes is rampant. But if you turn back the clock 50, 60 years, there's something clearly that was different about their population, the way they lived predominantly, that was protecting them. In Africa, for instance, you can also look at the Maasai, who lived on like practically all meat and blood and milk. They almost never eat vegetables. And this is very similar to the Inuit. So we think that vegetables are really, really necessary and good for you. But in the Eskimos, they ate a lot of seal meat, whale meat. They practically didn't eat vegetables at all. And yet they are very, very healthy. And it's the same with these Africans. So these Africans, which are eating meat and blood, they in fact had almost no high blood pressure and virtually no obesity. So you think eating red meat is really bad for you, and here these people are eating virtually nothing but red meat. And you think that eating fat is bad for you, but you have the case of the Inuit who are eating practically all fat in their diet, right? Whale blubber, seal blubber, that sort of thing. And there's practically no high blood pressure, there's practically no obesity. On the other end of the spectrum, you can look at this New Guinea highland tribe, which was extensively studied in the 1960s and 70s. And it turns out that these people ate virtually all carbohydrate. So 95% of their intake was carbohydrate. So in contrast to the other population, like the Maasai or the Inuit, who took virtually 0% carbohydrate, here these people are taking like 95% carbohydrates. And yet, they are also very healthy. Again, before the westernization, they had virtually no problems. No obesity, no diabetes, and very, very little cancer. The Katavans were studied in the 1990s, and they're actually just off the coast of New Guinea here, which is a tiny little island, and they ate really a lot of carbohydrates as well, close to 70% carbohydrates, lots of fish and fruit and vegetables and coconuts. And they again had no problems with obesity, they had no problems with blood pressure. But despite the fact that they're taking close to 70% carbohydrates, you can look at their serum insulin levels and you can see that they're very low. So remember in previous talks we talked about how serum insulin is really the key. And it's not just about the carbohydrates, but it's about the refining process and how that really takes away some of the protective factors such as the fiber and stuff. These people are eating, of course, completely unrefined foods. They're not eating, bread. They're eating, whole fruits and whole vegetables and so on. So when you do that, what they find is that this is their serum insulin levels. So this is the average, this line here, and the researcher was from Sweden, so he took the Swedish reference range, so between 10 and 90%. That's this shaded box right here. So the lowest part of this shaded box is the 10 percentile. That it means that 90% of the population has higher serum insulin levels. So this is virtually the lowest levels you will find in Sweden. And you can see that the average person in Katava who's eating almost 70% carbohydrate, their serum insulin levels are still lower than practically the lowest person in Sweden. So it doesn't matter so much that it's carbohydrate. So it's not the carbohydrate per se that's bad. It's the refining of the carbohydrates and the way that we eat it somehow in the Western world. So if you look at Okinawa, again, very, very high carbohydrate intake. However, very little sugar and very little refined foods, and their life expectancy is the highest in the world. They had very little heart disease, and their body mass index on average is only 20. So virtually no obesity despite the fact that they're eating 85% carbohydrate. So really what we can learn from these primitive societies and these studies of traditional societies is that you can eat really 95% meat or fat, or 95% carbohydrate, you can still be very, very healthy. The key is you have to have very low insulin levels. And what you don't find in these populations is this: refined or processed foods, flour and sugar. So those are really the keys that you see in Western society. Those are the foods that we eat a lot of, that they really practically don't eat at all: the flour, the sugar, and the processing. And that's a good place to start in terms of looking at toxicity and disease. If you look at populations in transition, so now there's been studies of populations that have gone from very traditional societies and moved to basically the Western society. And the best studied of these is called the Tokelo Island, which is a Polynesian island group. So they were very isolated, so they ate mostly coconuts and fish. And they were off the coast of New Zealand, so they eventually became westernized. If you look back, and they've been studied for a while, they had started in the 60s with taking a lot of fat because they ate a lot of coconuts, and a lot of saturated fat here in the green, which is, again, because of the coconut. And the carbohydrates are a little bit lower, proteins are fairly stable, but as they become a little bit westernized, what happens is that the carbohydrate tends to go up, the fats tend to go down. And in 1966, what happened was that there was a sudden change in that there's a threat of overpopulation of these little islands, so they moved them to the mainland. They moved them to New Zealand, and they studied what happened to their health as they went. So of course genetics are very important, but there are clearly no genetic changes within the same population. And this is what you see. So as they started to get more trading posts on the island, you can see that the sugar and the flour really tend to go up a lot. They still eat some rice, but in these little islands on Polynesia, they're not as important. But the amount of sugar and flour really increase a lot. If you look at the percentage of calories that you take from sugar, you can see that as they become closer to us, they go from 2% sugar to 14% sugar. I mean, the average for us is closer probably to about 20%, 25%, although recently it's been going down. And this is, of course, what happens to their weight. So if you look at the ones who migrated, so who went to New Zealand, there was a more drastic change in their diet. They become more westernized. Their weight steadily goes up as you go. But even as the island itself, you get these trading posts and you start to take sugar and flour, you can see that the weight steadily rises. And it increased by an average of 20 to 30 pounds over that period of time. So for all those who thought that the fat was really bad for you, you can see that the amount of fat, the percentage of fat calories, was actually going down significantly. Because, they ate a lot of coconut, which is saturated fat, but they're tired of it. They wanted to eat the bread and stuff. So they ate a lower fat diet, but their weight just kind of kept climbing. If you look at the diabetes, of course, goes along with the weight. So the amount of diabetes just kind of starts to go up and really shows no evidence of stopping. Gout, which is a disease, one of the diseases of civilization, again, is due to the high uric acid, and you can see that it starts to go up as well as tooth decay. So periodontitis or gum disease has been linked to various diseases, but that tends to go up as well, and that's probably, again, due to the sugar and the flour. If you look at the New Zealanders, you can take these native New Zealand tribes called the Maori. And what you see is that, some people say that there's a lot of physical activity is really good for you, and it is. It's just not that important for the weight, because you can see that the Maori are very physically active, so a very high percentage of physically active people compared to the total population, and yet their obesity is still much higher than the total population. So these people are still very physically active. It just doesn't make that much of a difference. So these are the Maori here, the men and the women, and this is the New Zealanders. And what you can see is that, of course, the staples of their diet changed over to become bread, flour, biscuits, and breakfast cereal. So all these highly processed foods, very highly refined carbohydrates. If you think about cancer, cancer is not always something we think about in terms of dietary, a lot of times we think we don't know what causes it, but there's clearly a link to the environment in most of our cancers that we see. So if you look at this is a study of the Inuit. So you can look at the westernization of their diet and their lifestyle changes and how that changes the impact in terms of cancer. So if you look at this is the males. They're traditional and lifestyle-associated cancers. So certain cancers are associated with lifestyle. So the most important are like breast cancer, colon cancer. Those are actually considered lifestyle cancers because they actually show a very big impact of lifestyle on the incidence. And what you can see is that as you go from the 50s to the 90s, so as the Inuit become more westernized, you can see that the traditional cancers, the ones that aren't so affected by lifestyles, still stay roughly the same, but the amount of these other ones, lung, colon, rectum, and breast, continuously go up. So again, it's not simply a genetic factor or maybe even an environmental factor, but there's clearly a change. With the change in the lifestyle to westernization, the rate of cancer clearly goes up. So these other ones, salivary gland, esophageal, the ones that don't show a link to diet and so on, they still stay the same. But these other ones, these common ones that we deal with, they clearly show a link to the increased westernization. If you look at these, so the U.S. Public Health, they looked at the Inuit again, and they looked at how much they have cancer, and they ranked them in terms of regions, in terms of the westernization. So some regions, people were still living very traditionally, and some regions, the Inuit were living much like the whites. And what you can find is that the white rate of cancer is much higher than the Inuit, of course, but there's a clear distinction between the ones who are who live traditionally in terms of cancer and the ones who live just like the whites. So there's obviously something. And one of the prominent lifestyle changes, of course, is the presence of flour and sugar. The flour and sugar don't spoil, so you can pack actually huge amounts and just carry it with you wherever you go. The explorers, of course, carried lots of flour and sugar wherever they went. So as opposed to traditional foods like meat and fat and whale blubber and that sort of thing, those things all spoil, so you can't transport them long distances, but sugar and flour you can. Even if you look at stuff closer to home, so if you look at Japan, for instance, and the rate of breast cancer in Japan, there's a large difference between the rate of cancer in Japan and the rate of cancer in North America. Okay, so you can see that there's kind of a 2 to 3 times risk of breast cancer in the United States compared to Japan. However, if you take Japanese women and you move them to America, within one generation the risk has increased by 60%. Within 2 generations, the risk is virtually identical. And the same goes for Chinese and so on. Whenever you move a society from the kind of traditional lifestyle to the North American lifestyle, there's clearly a change in the risk. So even though we think we don't really know what causes breast cancer and colon cancer and so on, there's actually a very clear link to the lifestyle. If you look at breast cancer rates in Hong Kong, for instance, they've also been steadily going up. Now, whether that's due to westernization, they've become much more westernized in terms of their lifestyle, or whether it's due to other factors, you can't say, but you can clearly see that there's been a rising incidence of cancer the more it becomes westernized. As opposed to China, for instance, China's huge and right there, but maintains a very, very low level of breast cancer, even through all these years, as opposed to Hong Kong, which has been steadily going up. So there's clearly a change, and it's not genetic because, genetically the Chinese and the Hong Kong Chinese are really identical. But there is a lifestyle component to that. And then if you look at heart attack rates, there's a huge difference between the rates of heart attack of Japanese in Japan and the Japanese in North America. And there's a huge difference in the rate of heart attacks between Africans in Africa and Africans in the United States. So if you look at San Francisco, if you look at the rates of heart attacks, so this is the whites, the Caucasians, This is the Japanese in Tokyo. So the same people, when you move them to San Francisco, the Japanese all of a sudden have heart attack rates which are much closer to the whites. And it's the same for the Africans. If you take Africans in Africa, their rates of heart attack are very, very, very low. These are the whites, the Caucasians. But as soon as you start moving these Africans to America, the rates of heart attack just follow the Americans. So even though there's a genetic component to these things, clearly there's a huge, huge lifestyle component to all of these diseases. And one of the first things that they imagined was the root cause of this. So everybody wants to know what is causing all this, right? Because you're taking populations that are relatively healthy and now they're becoming diseased. That gives you a clue as to what is causing the disease. And in the 60s, they came up with this refined carbohydrate disease. That's what Dr. Campbell and Dr. Cleve said was the cause of it. Because what they're saying is that they thought that all these diseases of civilization, the Western diseases, so cancer, heart attacks, strokes predominantly, are actually a single disorder. And they said this is actually, the cause is refined carbohydrates. So they called it the saccharin disease. Saccharin is a name for sugar, so sugar and flour basically. So it was the refined carbohydrates which were basically causing all of this disease. And he said that there's many different reasons that refined carbohydrates are going to cause all these diseases. One of them is that you tend to overeat them. You tend to eat more of them. Like if you have something which is very sweet, people will tend to eat more of it. So you tend to overconsume it. Because it's highly refined, our body hasn't evolved any kind of defenses to say, okay, that's enough. You should stop eating. For instance, if you think about something that's sweet, like an apple or something, you can't just keep eating apples until you eat the whole bushel of apples. Your body has natural satiety signals to say, that's enough. You don't want to eat anymore. As opposed to something like candy or, highly refined things like bread. Some people can just keep eating them until they're way more than full. The second is that you remove the protein when you refine these carbohydrates. So there's protein in a lot of foods, but the protein slows down the digestion. Because it slows down the digestion, the blood sugars don't go up as high, the insulin levels don't go up as high. That's another part of the refining that is very bad. It removes the fiber. Again, the fiber is probably a protective factor. So the fiber slows everything down. It slows down the rise in glucose, slows down the rise in insulin. And the fourth thing, it removes the fat. So all of these factors, the protein, the fiber, and the fat, they all slow down the digestion. So they slow down the rise in blood sugar and slow down the insulin. And as we've seen, the insulin is really the key factor in this. This in the 1960s and 70s, there was actually a huge debate back and forth whether it was the dietary fat or whether it was the refined carbohydrates. In fact, there was big clashes. They, attacked each other, and nobody knew what the cause was. Eventually, the dietary fat hypothesis won out. And so we've been concentrating for the last 30 years on removing the fat in our diet. It turns out that that may not have been the smartest thing, because if it was in fact the refined carbohydrates, because we removed the fat in our diet, we've removed one of the protective factors, and we're eating more of the carbohydrates because they're low in fat, right? Because we usually say to people, oh, you should eat lots of bread, lots of pasta because it's low in fat. But they're very high in these refined carbohydrates. So in the 1980s, this Dr. Gerald Reaven at Stanford, he devised this thing called the metabolic syndrome, which includes all of those risk factors which we talked about: obesity, high cholesterol, high blood pressure, diabetes, and they cluster together. And the fact that they cluster together means that there probably is a single underlying cause of the whole thing. And in fact, these things actually tend to cause the heart disease, the cancers, the stroke, all those things we think of as the diseases of civilization or the Western diseases. Turns out you can also add a few things, including Alzheimer's, gallstones, and fatty liver as well, to that list. So you can see that the key here really is the insulin. So not just for the risk factors in terms of the metabolic syndrome, and why it's important is that this increased insulin level is really the key to the whole thing. But it's not simply, the diabetes and the weight that's the problem. It's in fact your whole risk of these diseases of civilization. All of these heart disease, cancer, and stroke. So it's actually much more important than you think to control that insulin level, to really get that down. And that's why we really target that in what we do. And if you look at what, further research, you can see that high insulin levels have always been known to be a risk factor for disease. So if you take people and you look at their insulin levels, you can see that the higher your insulin levels, the risk of your heart disease significantly goes up. So it's clearly a risk factor for heart disease. And the importance is in terms of diabetes. If you think about the way we currently treat diabetes, we think of it this way. There's a lot of complications of diabetes. Diabetes is a terrible disease. You get all kinds of problems. You get heart disease, you get stroke, you get blindness, you get kidney disease, you get amputations, you get all kinds of problems. Okay? And we think of type 1 and type 2 diabetes very similarly. We think that it causes high blood sugars, and due to the high blood sugars, you get these complications of diabetes. So up until this point, the focus of our treatment has been getting your blood sugar down at all costs, even if it means giving you a huge amount of insulin. It doesn't matter, they used to think, if you got a lot of insulin because it was all about the blood sugars. So as long as you can stop the high blood sugars, you can stop the complications of diabetes. And that's what we all thought up until about 5 years ago. That's what a lot of doctors still think. The problem was that it wasn't true. Because about 5 years ago, what they did was there was 3 very large studies to look at that hypothesis. That is, if we lower the blood sugars, are we going to have less problems with diabetes? So they took people, this is the hemoglobin A1C. So they took 2 groups of people. One group, they controlled the sugars very tight. So their hemoglobin A1C was very good. And the other one was just kind of standard treatment. So your sugars are kind of okay. And the other group, the sugars were really, really good. But in order to get the sugars really, really good, they had to give them a lot more medications. And it turns out that, in fact, the risk of dying didn't go down. It went up. They actually had to stop this study because it was actually 22% more likely to die controlling your blood sugars very tightly. And this was a complete shock to everybody. I think this study came out in 2008. As a complete shock to everybody, because this was a complete change in the way we had to think about diabetes. That is, it didn't seem that it was just about the blood sugars. The blood sugars are important, but they weren't the only story here, because we controlled the blood sugars really well, and we didn't do better. We did worse. And this was a huge study. They had 10,000 people, and it cost millions of dollars to do. And the problem was that it wasn't the only study that showed that. There were 2 other very large studies that showed not that they did worse, but they didn't do any better. So even though you got a lot better in terms of your blood sugars, you weren't any better in terms of your heart disease. The thing I think that they forgot about was the insulin level. So the cost of controlling those blood sugars very tight is taking a lot of insulin and raising your insulin levels very high. And what the mistake I think they've made is that type 2 diabetes is a disease not just of high blood sugars. It's also a disease of very high insulin. And insulin is actually a toxic agent. If you look at basic science studies, you can find that there's all kinds of problems with insulin and hardening of the arteries, or the atherosclerosis. That is, if you give insulin, it tends to increase collagen synthesis, it stimulates proliferation of smooth muscle cells, it promotes growth of this atherosclerosis, and it causes insulin resistance. In other words, all of these things which cause the hardening of the arteries and the plaques in the arteries, they do worse when you give insulin. So there's a very good reason why you may think that insulin is actually really, really bad for you. And you got to realize that type 2 diabetes, not type 1 diabetes. In the type 1 diabetes, your insulin levels are very low, so it makes sense to bring them up. But in type 2 diabetes, your insulin levels are very high. If they're very high, you might think that it's not such a good idea to give more insulin since they're already very high. So it's possible that the increased insulin levels, which we give a lot of patients, we give them lots of insulin, but that the increased insulin levels are actually responsible for the complications of diabetes themselves, and it's not just about the sugars. In fact, when you look at studies, and these have all been fairly recent studies because we've had to look at diabetes a completely different way, but insulin treatment actually has significant toxicity. So if you look at this study, they took 12,000 new diabetics in Saskatchewan, and they looked at whether they're on insulin, a little bit of insulin, or a lot of insulin. And they looked at how they did, in fact, like basically how much heart disease they had, how they died. You can see that compared to not taking insulin, taking a low dose of insulin carries a huge risk, and taking a high dose of insulin carries an even bigger risk. Now, this doesn't prove anything by itself, because it might be that the people who have worse diabetes actually have to take more insulin, therefore they do worse. But if you look at differences between drugs, that is, you can control the diabetes with different methods. One is insulin, but there's another one called metformin, where you can control the blood sugars without raising the insulin levels. It kind of increases the sensitivity of the body to insulin, which is the metformin. And if you look at a comparison of metformin to people taking insulin, again, you can see there's a huge risk. So metformin, if you set the bar at 1, that means that's the standard, the reference. And you compare sulfonylureas, so this is glyburide, glycoside, some of the pills that you take which raise insulin levels. You can see that these pills that raise insulin levels compared to those that don't carry a 40% increased risk of dying. When you go to insulin, the risk is raised even further, up to 80%. Okay? So we think that it's all about controlling the blood sugars, but here it's saying that, well, there's actually a huge difference in the way that you control the blood sugars in terms of your risk of death. And this is a study that came out, again, very recently, 2010. So just after this whole shock to the system in 2008, when we figured out it wasn't all about the glucose, it turns out that controlling your sugars very tightly may not be that good for you. Okay, so this is what we thought. So if you take people on metformin, which is just the pill, now you step them up to another treatment, so the metformin plus another drug or metformin plus the insulin. And this is your hemoglobin A1C. This is how well your sugars are controlled. Now, we used to think that the better your sugars are controlled, the lower your risk of dying. So in fact, we thought that as you go higher and higher on your blood sugars, your risk is going to go up and up. And that is true. So when you go from an A1C of about 7.5% up, your risk of dying goes up. But when you're taking insulin, as your sugars get better and better, your risk doesn't go down, it starts to go back up. Now, if you just think about diabetes in terms of the blood sugars, you'll never understand why this is. This here, as your sugars go up, your risk of dying goes up, right? So this is the toxicity from the high sugars. But this is the toxicity from the high insulin. And you see the exact same thing when you look at drugs which raise your insulin levels. So as your sugars go up, your risk of dying goes up. That's fine. But as your sugars go down, your risk also goes up. And that's very interesting. And this is a very large study that was done. It was 20,000 patients that they looked at. So it wasn't just mere chance, one person here, one person there. If you look at people without diabetes, you don't find this relationship. In fact, as their sugars go up, this is within the normal range, as their sugars go up, their risk goes up. But as the sugars go down, it kind of stabilizes. It doesn't seem to go up after that. So this is what we used to think of should happen. But this is not actually what happens for diabetics. And you can understand that when you see that the insulin, when you understand that it's the insulin that's the key here. The sugars are important. We've always known that. But it's not just about the sugars. And in fact, in the very recent, I think in 2013, there was a new insulin which was introduced to the market. And the difference was that in the old days, kind of before 5 years ago, you could just introduce insulin and say, oh, you know, here's a new insulin, look, it controls the blood sugars, and then get it on the market. Starting a few years ago, about 5-6 years ago, they started to require that these companies keep track of the patients and see how they did. And so they introduced a new insulin, a new type of insulin. And they introduced it in Europe and Canada, but they, as part of the process, they actually had to keep track of these patients to see how they did. And so this is the first insulin that's ever had to go through that kind of scrutiny. And the very interesting, this was this insulin degludac, which was going to be a new generation of long-acting insulin. The problem was when they actually followed the people who were taking the insulin, their risk of heart attack went up by 350%. And their risk, so they said, okay, wait, let's look at it again, okay? They said, give us a second, let's look at it again. So they looked at major adverse cardiovascular events. Turns out there was still a 60% increase in the risk when they took this insulin. So the insulin wasn't good for you. It was bad for you. Not just a little bit bad. It was really, really, really bad. And this, of course, is the basis of our current treatment for diabetes. This is the first insulin. And of course, to this day, they still say, I don't understand what's going on. My insulin's just as good as the other insulin. And it was just the same as the other insulin. But those other insulins, they never had to go through this process. Where it gets very interesting is when you start comparing drugs. So there's two drugs, metformin and sulfonylureas. Metformin doesn't raise the insulin levels. Sulfonylureas do raise the insulin levels. So the sugars are controlled to the same amount. So it's not about the sugars anymore. You're taking the sugars kind of out of the equation because both sugars are trying to be controlled to the same rate. But new patients are either going to be started on metformin or a sulfonylurea. And when they look back at 250,000 patients in the VA system, and they compared the group that got started first on metformin to the group that was started first on sulfonylureas, there actually was a very large difference in terms of cardiovascular events. So there was a separation. As you take the sulfonylureas, the ones that raise your insulin levels, you actually do much, much worse compared to the ones who started on metformin. And again, there was a recent study coming out of China, which was a randomized trial. So 304 patients with coronary artery disease, they followed them for 3 years. So one group, they randomly assigned them. Okay, so one group, they said, you will take metformin. One group, you'll take sulfonylureas. The sulfonylurea group is the group that has their insulin levels raised by that medication. And when they compared the glipizide to the metformin, you can see that there's a higher risk of death, a higher risk of heart attacks, strokes, and revascularization, or balloon angioplasties. So the total is that a huge difference in terms of complications, depending on which drug you got started on. And remember, the sugars are being controlled to the same level. So it's not just about the sugars, it's about the insulin. So what happens when you control your sugars without raising the insulin levels? Because that's really what we're trying to do. If you look at the ORIGIN trial was a very large study, 12,000 patients with type 2 diabetes. They had impaired fasting glucose, so they said that one group we're going to give a lot of insulin and control their sugars really, really well. The other group, well, we'll just leave them be, right? And after 5 years or so, they actually couldn't find any difference. There was no difference between the two of them. You know, so tight blood glucose control didn't seem to make any difference. But the problem, of course, that they're giving insulin to control blood glucose. So you're trading the toxicity of the glucose for the toxicity of the insulin. Another study looked at lowering blood sugars without raising the insulin. So they gave this other drug, which we don't use a lot of anymore, called acarbose. And they randomized 1,400 patients. They followed them for 3 years. So again, one group, they said, very similar to study to the previous, but instead of using insulin, They said, we're going to use this drug, and it blocks the absorption of carbohydrates so that you don't absorb it. What they found, instead of no difference like the insulin, what they found is that there was a huge difference. That is, the people who they controlled the blood sugars but didn't raise the insulin, they had almost a 50% reduction in these adverse events, so cardiac events, which led to a 2.5 absolute risk reduction, which is actually very, very large. So almost a 50% protection when you're able to control the sugar without raising the blood glucose. And what's very interesting, too, is that high blood pressure was significantly impacted. And again, you can understand that when you think about the whole metabolic syndrome is actually affected by the insulin. So high blood pressure is one of them. And you can see that the ones who they were targeting and lowering the insulin levels on, lowering the sugars and not raising the insulin, they actually had much, much less high blood pressure. So if you look at another class of drugs, which are relatively new, so these are the so-called DPP-4 inhibitors. So that's the Januvia, Onglyza, Tradjenta, which some of you might be on. You can see that if you look at their risk profile, because they don't raise the insulin persistently, they may actually have a significant cardiovascular protective effect. So they may actually help protect you against the damages of the diabetes much, much more than previous. And again, when you think about it in this way, you can see that this is still the key to the whole thing. When you ignore this, when you give people treatment for your diabetes, but you give them tons of insulin, it doesn't help because you're still driving everything through. I think it's a big mistake to do that. If you look at diabetes, for instance, the American Diabetes Association doesn't really believe this, actually. They think that sugar doesn't really matter. As recently as 2008, as crazy as that sounds, this is what they said. Intake of sucrose and sucrose-containing foods, so sugar, basically, by people with diabetes does not need to be restricted because of concern of aggravating hyperglycemia. So as crazy as that sounds, this is taken straight from the American Diabetes Association advice. You don't need to worry about sugar. I mean, that's crazy. What they instead tell you to do, this is 2008, so it's a few years ago, but what they instead tell you to do is reduce calories and reduce dietary fat because they think that's really important. In other words, you should eat a little less, you should watch the fat in your diet. The problem was that it doesn't work. So again, we've had multi-million-dollar trials to look at reducing calories and reducing fat. So this is one of the studies that they did. It's published in the New England Journal of Medicine in 2012. And what they did is they took 699 patients and they randomized them. So one group they gave just the metformin, and one group they gave metformin plus this lifestyle. The lifestyle treatment was a low-fat diet, exercise, right? So eat less, move more. That's what they all say, right? So eat less, move more. The problem was at the end of it, they couldn't find that there was any benefit. The p-value is 0.17, so there was really no benefit to this lifestyle modification, this low-calorie, exercise, low-fat. There just was no benefit. So when they tried to figure out what was going on, instead of really trying to understand, they couldn't believe that their own advice to eat a low-fat diet was wrong. So they said that, well, eating too many calories is the central cause of type 2 diabetes, which I think is completely wrong. Calories are not really all that relevant. What's relevant is the insulin. It's the insulin that causes the obesity, not the calories. So, the second thing that they're saying is that because changes in eating and activity were calculated to decrease baseline weight by 7 to 10%, most participants clearly did not adopt these habits. So instead of trying to find out where they went wrong, they just started blaming the patients, which is blame the victim, which they do all the time, right? They all say, it's your fault, right? You're fat because it's your fault. They don't understand that the nutritional advice that they've given has never worked in the history of dieting. The low-fat, low-calorie diet just doesn't work. It's never worked. It hasn't worked in 50 years. Yet they think it still works, so they start blaming the participants in this study. And what they said that lifestyle changes by definition works, and that any lack of effect is therefore due to poor adherence. Again, more blame the victim. And this is not just some guy spouting off his mouth. This is some doctor writing in the most prestigious medical journal in the world, practically. And what he's saying is that we think it's their fault. We think it's their fault. All our advice is good. We think it's their fault. I think that they should have gone back and looked at their advice, because I think it's wrong. So this is really the advice that has never worked, ever. It's got a perfect record, unblemished by success. It's never worked. It hasn't worked in 50 years, and yet they still think it works. And in fact, more recently, there was another headline in Forbes. They said, NIH trial of lifestyle intervention for type 2 diabetes stopped for futility after 11 years. So if you look at what they did for diabetes, they put people, so 5,000 patients, on a low-fat, low-calorie diet. So 1,200 to 1,800 calories per day. And they had meal replacement products, highly processed meal replacement products. And they increased their exercise. So again, the same kind of failed advice. Eat less, move more. So they wanted less than 30% calories from fat. And what they did was they followed them for many, many years, right? So low-fat, low-calorie diet, increased exercise. The problem is that it's been futile. This is the sort of advice that has never worked. So yes, they were able to maintain their weight a little bit lower. So they were able to increase the physical fitness. So yes, they did what they tried to do. However, if you look at the risk of heart attacks, there's no benefit. It doesn't work. There's no difference. So for 10 years, 1,200 calories a day, that's very, very little, right? So they're restricting their calories, they're exercising, but it just has no benefit. There's no difference. And of course, they don't understand why this didn't work. They still think they're still probably blaming the patients, right? But in fact, the patients were doing exactly what they're telling them to do. So you got to realize that this sort of advice just has never worked for diabetes. And it's completely insane to keep giving the same advice over and over, and it keeps not working, keeps not working. You spend like hundreds of millions of dollars studying these people, trying to show a benefit, and when there's no benefit, you don't change your mind. You have to think, what is it that was wrong about the whole way that we thought about things? And the thing is that the target is not calories. Even exercise, which is good for you, is not the major problem. The major problem is the increased insulin levels. And that's the part that they never get. If you look at carbohydrates in diabetes, you can start to see that there actually is a very clear correlation. So if you look at Chinese women, for instance, if you break them into quintiles, so 20%, the highest group of dietary carbohydrates, the ones who eat the most carbohydrates have the highest risk of diabetes, and the same for the second. After that, it doesn't seem to make much difference. If you look at low carbohydrate diets, for instance, you can see in small diets, you can see that the hemoglobin A1C tends to come down. So there are trials where they take people and put them on low carbohydrate diets, and their sugars seem to improve. If you put them on low glycemic index diets, again, you can take this one from, I think this was from Dr. Jenkins, and he put people on a high cereal fiber diet, so taking lots of fiber, which should be good, it's our standard advice, and compared them to a low glycemic index. You can see that the low glycemic index did better in terms of weight, and also did better in terms of their sugars. And this was really brought home in 2009 when they looked at the so-called Mediterranean diet in treatment of diabetes. So Mediterranean diet actually tends to be higher in fat because it tends to emphasize things like nuts and olive oil. So you can see that if you treat diabetics, not with a low-fat diet, but with a higher fat diet, the Mediterranean diet, what you find is that a lot less of them are going to need drugs. If you look at the weight loss, so it's better in the Mediterranean diet, you lose a bit more weight, but the sugars are much better. You get much better insulin resistance. But the thing is that the amount of people that require diabetic medication afterwards is much less. So 40% will still need medications, but on the regular low-fat diet, it's 70%. In other words, over 4 years, you can reduce your risk of requiring medications by close to 60% by following a high-fat diet, a so-called Mediterranean diet. If you look at things such as wheats versus beans, for instance, beans are very, very low glycemic index. They don't really get absorbed very well. You can see that there's, if you put beans, you have better weight loss and better, so this is the wheat arm. So the wheat arm does not bad in terms of weight loss, but you do better when you do beans. Your waist circumference does better, but you also lower the blood pressure and diastolic blood pressure much more when you add the beans. And another type of diet, which is also very good, is the so-called Paleolithic diet, which is instead of, they compare two groups. So a whole grain, low-fat dairy, which is kind of our standard dietary advice, compared to a paleo diet. Paleo is the so-called caveman diet. So you're supposed to eat everything unrefined. So no cereal, no margarine, no sugar, that kind of thing. But you can eat meat, you can eat vegetables as long as they look like the vegetables that grew out of the ground, right? But no flour, none of that. And what you can see is that the sugars seem to do much better. The Paleolithic group drops their blood sugars, so hemoglobin A1C much more, and the weight seems to go down much more. And if you give people a lot of fiber, again, you can increase their insulin sensitivity. So the fiber acts almost as an antidote to a lot of these carbohydrates. And if you look at the usual group, the fiber group does much better in terms of that. So you can see that all these diets, they target the serum insulin, which is the proper target that you have to take. If you look at other diseases, such as heart disease, you can see that our standard advice to eat a low-fat diet was basically an epic failure. Okay? So there is something called the Women's Health Initiative, which is a huge study of 48,000 patients. 48,000 women, and they followed them for 8 years. So a very, very large, expensive trial. And what they did was they told people to take low-fat diet, 20% of calories. So very low-fat diet, eat more whole grains, eat more fruits, eat more vegetables. After 8 years, no benefit, completely no benefit. Okay? Of course, this came out in 2006, and we're still telling people to eat a low-fat diet. But it simply doesn't work. You spend hundreds of millions of dollars proving that it doesn't work, but you haven't changed your dietary advice. If you look at stroke, again, a complete failure. There was no benefit to the low-fat diet. But if you look at carbohydrates and their correlation to heart disease, things start to get a little bit more clear because, again, if you look at this very large nurses' health study, this is a weaker study trial design. This is just an observation. But you can see that those people who tend to eat the highest glycemic load tend to get the most heart disease. And the lowest tend to have the least. So if you eat a very low glycemic load, you do better. And as you eat more and more, it gets worse and worse. And this is 10-year follow-up. And the risk is driven mostly by the sugar, actually. So even if you compare the starches and the lactose, lactose is like milk. Even the starches don't seem to be quite as bad as the sucrose, which is the sugar, and the fructose, which is found in sugar and high fructose corn syrup. Most of that risk seems to be driven by the sugar. It seems that the sugar is extra bad for you. And we can understand that because the sugar causes the insulin resistance, as we talked about before. And if you look at the risk of heart disease, you can see that this is the risk of heart disease, and this is the glycemic load. So as your weight goes up, your risk of heart disease goes up, but as you take more and more of these foods that raise your glycemic index, that also causes you to have higher risk of heart disease. So there's a clear relationship between carbohydrates, between the glycemic load of foods. And if you look at this one, this is a study where they looked at angiograms. So they went in, they took pictures of the heart and saw how blocked they were. And they took 235 women and they followed them. So 3 years later, they looked again to see how much blockage of the heart artery there was. And it's very interesting because if you look at this is so the white bar here is the fats, okay? This is the protein and this is the carbohydrate. So this is the quartile. So as you eat more and more of this carbohydrate, so this is the most carbohydrate intake, highest carbohydrate intake, you see that you get the most narrowing of the arteries. right? So if you eat a lot of carbohydrates, so low fat but carbohydrates, which is what we've told people to do for many years, you get the most progression of disease. And again, that's very easy to see when you think about it in this standpoint. So you can see that both diabetes and heart disease clearly fall within these diseases of the civilization, which are clearly driven through this pathway of increased insulin. Cancer is a really interesting thing. Diabetes actually is one of the really bad diseases, but one of the risks of diabetes is that you can get a lot of cancer. So almost all of these cancers, for breast, colorectal, endometrial, all of these cancers, you see an increased risk in diabetics, but it doesn't tell you whether it's because of the high insulin or it's because of the insulin resistance. The low-fat diet, so this huge women's health initiative where they tried to use a low-fat diet, it didn't actually reduce the incidence of breast cancer. They thought maybe, perhaps, but they had to study 48,000 women, and they couldn't really find a difference in terms of cancer. So the low-fat diet was really a complete failure in terms of reduction of cancer. But when you look at drugs that reduce the insulin levels, it looked like metformin might actually reduce the risk in diabetic patients. So again, I don't think it's the metformin that's good, it's that probably the other ones that raise the insulin are bad. Okay? If you look at metformin compared to any of the other drugs, so back then there's only metformin versus insulin and sulfonylureas. So the comparators tend to raise insulin, the metformin tends not to, and you can see that the ones who took the metformin had a much lower, close to 35% lower risk of developing cancer compared to all these drugs which tend to raise the insulin and sulfonylureas. So if you look at insulin, in fact, insulin looks like it's extra bad. So if you compare it to people who don't take insulin, the ones who do take insulin have almost a 90% increased risk of cancer. If you look at the drugs which increase your insulin levels, so the sulfonylureas, they're not as bad, but you're still looking at a 30% increased risk of cancer by using those drugs. And it's probably due to the high insulin levels. The insulin itself, if you look at metformin plus the sulfonylurea, you get a bit more risk. The sulfonylurea, you get a bit more risk. And then the insulin, you get the highest risk. Okay, so different treatments for the diabetes might show a difference in terms of cancer risk. Okay, so this is a group of 62,000 patients which they looked at. Fairly recently, 2009, it was published. And again, so you can put cancer on this list of diseases of civilization, which are clearly driven through the insulin. Gum disease I'll just mention because it gets mentioned sometimes. There was this idea a few years ago that gum disease is related to heart disease, and that's true. So they thought, well, because they're correlated, they might be causal. So gum disease might actually cause heart disease. So they actually spent serious money trying to look at, brushing your teeth, can it reduce heart disease kind of things. Turns out, of course, there was really no benefit. But they spent a lot of money on this. And really, the link is very easy to see. I mean, sugar causes cavities. Okay, that's pretty easy to understand. Sugar, through insulin, also causes diabetes, heart disease. So clearly, they have a similar cause. But it doesn't mean that the cavities cause the heart disease. That's not that smart. I mean, but we spent a bit of money to look at this correlation, and they put a couple studies, brushing teeth and all this stuff, to look at if reducing cavities reduces heart disease. No, it doesn't. But the link is very easy to see when you think about it this way. It's all related back to the sugar. In fact, if you look at, if you read some of the classic works of some of the other original doctors, they consider gum disease a canary in the coal mine. That is, that's what's telling you you're at real high risk. Because all those societies which started to develop cavities because of all these sugars and refined carbohydrates, they also then went on to develop a lot of heart disease. It had nothing to do with the cavities, but it had everything to do with the thing, with the flour and sugar. So it actually is a very useful indicator for that. So you can see that all the diets which are really successful are the ones that target the insulin levels. And that's really the key to the thing. The diet not only relates to all of the metabolic syndrome, the high blood pressure and all that, but all of the diseases of civilization. And that's why we really have to worry about it, because on all those societies where their diets really had very low insulin levels, they really had none of this stuff. And this is all the stuff that we spend, billions and billions of dollars, treating. And the problem, of course, is that we give a lot of people insulin. And that's the real problem. If insulin is the problem, it's just going to drive all these other problems, and you're not going to see the benefit. I think that's the last slide. Any questions about that? That's good. Okay.